Good morning, everybody. I'm John Kirwan. I'm Professor of Rheumatic Diseases here in Bristol. As part of my job, I do research into the causes and treatment of arthritis. And I'd like to share with you something that makes our research better.
Hello, I'm Pam. My name's Pam Richards. I work with John and many members of his team and other people as a patient research partner. I've had rheumatoid arthritis for 30 years and I wake up with it every day. It doesn't just affect my hands. People look at me and think it's just my hands, but it affects every joint from my jaw to my toes. It's very painful, it causes a lot of stiffness and obviously damages joints, which makes even doing very simple things like getting dressed quite challenging, and some things are impossible. So I've been working with John for a number of years to help them to really understand what it's like to live with arthritis.
So when we do research on arthritis, we turn to our patients to give us different insights from their point of view. And we'd like to use an example that Pam's been involved with.
Another big problem with rheumatoid arthritis is fatigue. It's something that you can't see, and everybody says, but I get tired as well. But fatigue with rheumatoid arthritis is completely different from normal tiredness. You get totally and utterly wiped out, very, very exhausted for no reason whatsoever. And it's very frustrating because when you go to the doctor and you say, I get really drained and really tired, they can ignore it or dismiss it because they don't recognise it. But since I've been working with John, there have been developments.
Well, that's true. We didn't recognise fatigue, and we never asked patients about it, and we never offered them any treatment for it. But when we started to involve patients directly in our research discussions, got them around the table and started talking to them, they made it clear to us that fatigue is a really big problem and is central to their life. So we did some more research on fatigue here in Bristol, with colleagues in Europe, in North America. We came together at an international meeting, and we all agreed that measuring fatigue and treating fatigue was a really important part of arthritis. And there's now been an international agreement that in all studies of new treatments for rheumatoid arthritis, fatigue will be measured. And pharmaceutical companies have rolled this out across the world and are incorporating this into their work now. But of course, getting patients involved in this sort of detailed discussion about research projects and how they should be managed isn't easy, and it offers challenges to patients. What sort of challenges did you face, Pam?
When I first got started on a research project team, I was really unsure about what I could contribute because I didn't come from a research or medical background. My background was in banking, which had nothing at all to do with research. So I didn't understand the medical and research jargon, of which there is an awful lot. We now have a very good glossary, thankfully. Sometimes I'm sitting in a group with very eminent people and me, and it can be very intimidating, and you have to try and speak over some people who like to hear the sound of their voice quite a lot. So it can be quite challenging. But I also thought that doctors such as John and his colleagues knew everything there was to know about rheumatoid arthritis. But I quickly found they didn't know quite everything, that their learned knowledge had gaps that my lived knowledge could point out. But there are also, that sort of really helped me to contribute to your research.
But there's also challenges for doctors. So we now wouldn't dream of doing a research project in our department without having patients involved. We've had more than 40 patients involved as partners in our research projects, from the design, implementation, analysis, and publication of the results. But researchers themselves face some challenges in doing this. And how do researchers get started on involving patients? Well, the first thing to do is to learn 3 new skills that aren't normally taught. The first one is how to identify and recruit patients who are in a position to offer help and support, who are going to be able to speak up, who are going to be able to understand what you're talking about. The second thing is to offer them support so that when they're at the meetings and there is jargon, it's explained so that they are introduced to the team, so that they have the paperwork, they have personal support to be able to manage in that situation. And the third thing is the researcher has to be able to listen. The patients do not know when they tell you something important. They're just telling you about their experience. It's up to the researcher to develop the skill to listen to when the patient says something that makes a difference to hear that word fatigue and say, hello, what's that about? I hadn't thought about that before. So we have to listen.
And that really helped me when I first started. I realised from a comment actually John made quite early on that I didn't have to say anything clever. All I had to do was share my own experience. And it was up to other people to take out from what I was sharing the things that were relevant to that particular project. And that just gave me that sort of sense of taking away the stress of having to come up with something. So my learned knowledge complemented what John and his team needed.
But it's not just healthcare, is it?
No,
I mean,
no.
we think that this process of involving the people that you're working with in the actual development of new thoughts and ideas is itself inherently useful. For you, whoever you work with, whoever you serve in your job or your role, you should be involving them in decisions about growth and development. We think that working together in partnership with those that you serve will produce dividends.